presenting a case of low sodium, think pituitary. Hypopituitarism tends to be an overlooked cause of hyponatremia. We present a case of a 55-year-old female who presented with syncope and was found to have hyponatremia. Lab studies revealed hypopituitarism with marked improvement with glucocorticoid replacement. This is a case of a 55-year-old female with past medical history of vitamin B12 deficiency who presented with an episode of syncope. She denied any warning signs or prodromal symptoms. She endorsed nausea, early satiety, dizziness, unsteady gait, and a weight loss of 20 pounds over the past 6 months. Labs showed a sodium level of 123. A CT scan of the brain was unremarkable. However, an MRI revealed nonspecific findings of partially empty sella. Further workup of the patient's hyponatremia revealed TSH of 3.8 and free T4 of 0.5. This raised concern for possible underlying adrenal insufficiency. Her morning cortisol level was low normal at 5.5. This was followed by a cosentropin stim test, which resulted in a basal cortisol of 3.7, with increase to only 10.4 in 30 minutes post and 12.4 1 hour post cosentropin injection. An ACTH level was also low normal at 8.2. Subsequent workup revealed markedly decreased FSH at 2.0 and LH of 0.6. Endocrinology was consulted, and per their recommendations, the patient was started on glucocorticoid replacement with hydrocortisone. After 24 hours, levothyroxine was initiated. The patient's sodium status also gradually improved to 136 upon discharge. The patient was followed up outpatient and reported that she felt the best she had in years. So our patient's persistent symptoms prompted evaluation with MRI, which revealed empty sella. This is a nonspecific finding, but this led to further workup involving the hypothalamic pituitary axis hormones, including ACTH, morning cortisol, FSH, and LH. This made us suspicious of possible adrenocortical insufficiency at this point, and we performed a cosentropin stimulation test. Generally, we consider an increase in cortisol by more than 20 to be a normal response, which would deem adrenal insufficiency unlikely. However, given that our patient had a low basal cortisol to begin with low ACTH and suboptimal cortisol response to cosentropin, secondary or tertiary adrenal insufficiency became high on the differential. In postmenopausal females, the anterior pituitary hormones, FSH and LH, are expected to be elevated. In our patient, they were decreased, and this is consistent with hypopituitarism. Symptoms reflective of ACTH deficiency include postural hypotension, tachycardia, fatigue, weight loss, hypoglycemia, and eosinophilia. Previous studies have shown that hyponatremia may be a valuable initial manifestation of hypopituitarism in the elderly. In this case, the patient's age was only 55 at the time of diagnosis. In conclusion, we state that it's important to have a high index of suspicion for hypopituitarism, not only in elderly patients, but also in those younger. Hyponatremia may present in central adrenocortical insufficiency, since glucocorticoids are required for appropriate free water clearance. And treatment of hypopituitarism with glucocorticoid replacement therapy usually leads to prompt resolution of symptoms, which ultimately translates to overall improvement in patient health, outcomes, and quality of life. Thank you very much.